All right, great. Thank you everybody for attending both in person and virtually. My name is Sudha Jayaraman. I'm one of the surgeons here at the University of Utah and direct our Center for Global Surgery. Over the last year, folks from multiple different departments across the university have had conversations about how do we create a global health community across the university that really pulls people from multiple departments. And so a group of us decided we're just going to do it. So that's what this series is all about. And it's a monthly global health research grand rounds. And I am grateful to my partner, Dr. Nunez, to be the inaugural speaker of this grand round series. Dr. Nunez is an associate professor of surgery and has been involved in work in both Mongolia and Ghana for a number of years, most recently completed a grant by the Laerdal Foundation to study access to surgical care across the entire country of Ghana after having done something similar for the entire country of Mongolia. And the reason this is important, which I'm sure he'll get into, is that, surgical care is a part of healthcare, and we need to think about what access to surgical care looks like. And there have been a lot of papers written on what those metrics should be, and there's been a lot of work done on how do you collect those metrics, how do you validate them, et cetera. And hopefully Dr. Nunez will tell us all about his experience. So thank you so much for making time to be here.
Great. Well, thanks so much. Okay, we're better now. No, we're not. Sorry.
Okay, is this better? Well, thanks so much, Dr. Jayaraman, for selecting me to be a guinea pig for this. I'm very happy to do it. We've all wanted more sort of cohesion amongst people interested in global health, so I think this is a great venue to start conversations, and maybe there are areas of research and the like. So as Dr. Jayaraman mentioned, I'll be speaking on, let's start with global health metrics as a whole, why we collect them, the strength behind them, the pitfalls inherent in them that we should be aware of, and then I'll talk about how that's impacted global surgery, where that's come from, and then we'll touch on my own work. So I finished training a decade or so ago, and I cast sort of a wide net and ended up at the University of Utah, in no small part because I wanted to explore global health and what that looked like for surgery. There's been a long-standing collaboration among Price and his colleagues, thinking laparoscopy, and they've really been able to show impact in that educational model and spread laparoscopy across the country. So I got to be a part of that. Coming in here, I got to be part of bringing formalized trauma training to the country. And as I got comfortable, Dr. Price said we should probably collect the Lancet Commission's surgical indicators. So I said, sure, why not? Not really knowing what I had taken on. But I'm glad I did, because I've just kind of cast myself head first into it. When it came time for a midlife crisis, I opted out of the Porsche. Went to grad school instead, so I'm in it. So let's jump in. What are indicators? I promise this is the only wall of text I'll put up today. But I love this quote so much, and I think it captures indicators so perfectly. It's from the Palgrave Handbook on Global Health Data Methods. So indicators are succinct summaries of sometimes sophisticated data collection and analysis. Their simplicity is effective. Indicators can stimulate a member of the public to organize for change, a patient to insist on her rights, a researcher to initiate a study, or a program manager to review an intervention, a donor to prioritize differently, or a policymaker to reallocate funds. Indicator simplicity can also mislead. So to jump into this, I was sort of overwhelmed by the sheer number of indicators. These metrics have been used in global health to measure for the better part of a century, but the increase in number and the sort of fascination with them really took off in 1978 at the Declaration of Alma Ata, which we'll talk about a bit more. But it came with about 19 national indicators meant for countries to collect and guide their population toward primary health care. As the 1990s moved along, more indicators mounted. There were children's goals, childhood mortality and diseases. WHO and UNICEF had a lot of different AIDS, HIV, and other infectious disease indicators. And then more came along with the 2000s, with the Millennium Declaration. In 2015, the SDGs had about 232. So the WHO sort of realized at that point that there were a lot of countries routinely collecting and reporting over 600 indicators to different funding agencies, to different programs, and to different sort of international mandates. And a lot of these were redundant, the definitions were vague. So they made an effort to narrow these down to a core group of about 100, and made it much more reasonable to do. So, a lot of them. It's worth, before diving into these things, before doing this kind of research, seeing the results, or getting the global health in general, ask a few questions. Are global health metrics neutral? Where did it come from? What are the ideological drivers behind them? They're different for different indicators. And what are the objectives of indicators in general? So back to 1978, at Alma Ata conference, it declared the goal of healthcare for all by the year 2000. And to their credit, it was primary healthcare. People should have access to primary healthcare. And almost every country in the world signed on to this. It was motivated to address sort of root causes of diseases, more of a holistic approach. The thing about 1978 is that it was sort of hip deep in the Cold War. And this all seemed pretty commie talk to a lot of people, a little too socialist. And the Bellagio conference followed about a year later. And the Bellagio conference was put on by the World Bank, which has also supported the Alma Ata conference. There are a lot of Bellagio conferences, but this one in particular pushed an agenda called selective healthcare, selective primary healthcare, with the idea to focus on economic metrics to properly allocate resources. As time went on, this culminated in what we all know as the DALI, the Daily Adjusted Life Year. And this is sort of the chief metric of global health of the 90s and up until today. It's basically described cost effectiveness, how much disease burden we could alleviate, and put sort of a dollar figure to it. So I initially wanted to describe these as sort of competing philosophies of global health, but I think they're two sides of the same coin because they both really have their place. More holistic health side from the Alma Ata conference and promotes that community-centered care. It addresses basically the social determinants of health, the importance in investing in infrastructure and sanitation and housing to improve health, which will then eventually improve the economy. The other pole is economization and the global burden of disease metrics, which focus on metrics like the DALI, more cost-effective in nature. There are consequences to each of these, and they each have their own indicators. The Alma Ata conference put out 19 of them. They were mostly disease-specific and very interested in mortality. The argument against was that mortality maybe isn't the best way to allocate resources because it's such a complex topic. And so The DALI is controversial in part because they're sort of weighting life years, they're valuing younger life over older years of life. It's probably a whole few hours, it's probably a whole lecture series, I would imagine. So what are the strengths of health metrics? Ideally, they allow global comparisons and a standardized language for tracking progress. They provide accountability, driving government responsibility and resource allocation. And well, we'll get into that. They impact policy as well if they reach the right people. Really, they're short, pithy. This is our problem. They're simple, and that's why they're effective. Again, it's also why they mislead. They're too simple. They fail to capture local contexts. They're insensitive to those contexts. And we've grown probably into what can be described as a data fetishization in global health. This affects government programs. This affects departments of public health, global health programs. You need to prove to your funders that what you're doing has had impact, for one, which is good. You should. But when it takes up most of your time and takes that time away from actually providing care, sometimes that can be a real problem. And they are inherently political in nature. They emphasize global priorities over local needs. Going back to the Global Urgent Needs Project, that's funded by the Gates Foundation to get good data and to prove impact, but they're also the ones funding programs. So I don't question their motivation, but sometimes you can question bias in that situation. So surgery. 2015 was a big year for global surgery. We had sort of long lamented ourselves as a neglected stepchild of global health. And it's probably for good reason. It's not very practical to upgrade a surgical system. It's hard. It's not as simple as hygiene projects and implementing a silver bullet. You need supply chains. We need facilities to do surgery. You need experts and nurses and a whole bevy of things. You need funding, a lot of it. All this culminated, or rather kicked off by the WHO Resolution 6815, which encouraged strengthening of emergency and essential surgical care and anesthesia in the context of universal health coverage. Now, from a holistic health standpoint, it's obvious, right? It's pretty darn hard to cure cancer if you can't do surgery. You can't deal with a lot of the effects of HIV without surgery. You can't get people back to work without surgery. And there's a whole lot of healing that takes place in the operating room, sometimes more often than anywhere else. But no one was listening for the previous couple centuries. And so the Lancet Commission on Global Surgery was formed, and they played the game, basically, right? They made the economic argument. They measured the burden, which is 5 billion of the world's population with no access to safe and affordable surgical care and anesthesia. I should take a moment to clarify that surgery is not just surgeons. Surgery, anesthesia, and obstetrics, and that covers a lot of ground. There are 143 million additional surgical procedures needed in LMICs each year. And if we don't address it, the estimation is that the global loss in productivity at 2030 will be about $1 trillion. And by contrast, it'll take about $350 billion of investment needed to reach the Commission's goals. It leans further into the economic argument and actually applied dollar per dolly averted by investment. And it lists a bunch of procedures here and a bunch of or a handful of the more accepted global health interventions. And you can see that certain kinds of surgery are more cost-effective investments than things like, aspirin and beta blockers for ischemic heart disease, antiretroviral therapy for HIV. There are even, some general surgery procedures and the like, and minor procedures that are more cost-effective than vaccines. And so when you look at these things in this light, and in other metrics like value loss output for GDPs and all the like, they really lean into it. Pretty strong argument can be made for governments to invest in surgery. It's not a small number, but neither is the rest of these things. So, Jade, go collect the surgery indicators. Okay. What does that mean for Mongolia? And to introduce you guys to Mongolia, it has the population of Utah. And if you didn't know, Utah is a pretty sparsely populated state. But it's as if you would stretch Utah from Salt Lake City over to Cincinnati, up to Omaha and down to Dallas. My favorite standard unit of measurement for countries is how many Texases. And Mongolia is 2.3 Texases. So I'll give you some idea of what we're dealing with and what the Ministry of Health and Health Development Center in Mongolia is dealing with. As a middle-aged man, I will show you my drone footage. You can be a barbecue dad, you can be a history dad, I'm a drone dad. So this is us accompanying an ambulance from a hospital in the Gobi Desert and taking a patient back to her her homestead for the season. She's like a third of the population. She's at least semi-nomadic. And so she had to get to the hospital to get her laparoscopic gallbladder that we very proudly assisted with, and over the long term provided that capacity for her. But this illustrates what Mongolia is dealing with on providing access to a big chunk of their population who lives very remotely. And so, I like to use this conceptual framework on how we've designed indicators for global surgery. And what our aim is to measure access to safe surgical care. So what is access? That's the first question. And access comes in lots of different phases. Starting here. If you're a patient, countryside, if you're this lady, can you get to a facility in a timely manner? Now, we describe timely as 2 hours based off maternal hemorrhaging. If the answer is no, that's not access. Does the hospital you reach have capacity to perform surgery? It doesn't. That's not access to surgery. Is it safe? No, then no access. Is it affordable? You get it without it being financially toxic to you, being a huge financial stressor. If not, it's not access. And importantly, this button can also be located back here. This woman knew that her gallbladder surgery was not going to, or was going to prevent her from feeding her family. She might not have sought care in the first place. So if it's too expensive, that's not access either. So here are the indicators, and they're broken up along these lines. The first two describe preparedness. It's that 2-hour access to essential surgery. The best way we found to indicate essential surgery is what we call bellwether procedures. If a hospital can perform a C-section, a laparotomy, and internal fixation of a long bone fracture, they can probably do a lot of other stuff. And that essential surgery covers about 80% of the surgical burden of disease, which is a whole lot of the global burden of disease. So we're talking about district level hospitals here who basically address this with what we would consider a pretty low level of intervention. We measure surgical workforce density as part of this preparedness. Are there surgeons, anesthesiologists, and obstetricians who can do this stuff? For service delivery, we look at surgical volume nationwide, and that's sort of per 100,000 density measure. Look at perioperative mortality, one of the ones in that 100 core indicator group. And then cost protection is interesting. We look at both impoverishing expenditure, which is, if you get surgery, will it drop you below the poverty line? Catastrophic expenditure is, no matter your income, if the cost is big enough, will it cause you a financial shock? It'll make you uncomfortable. You have to make some adjustments. We have to borrow. You have to lean on your neighbor. You have to eat less. The list goes on. So, Mongolia's indicators. In Mongolia, I was at an advantage. So there's all kinds of ways we can measure indicators. Lancet Commission didn't prescribe any ways in particular, but hopefully you look at national data. If you look at the World Bank income classifications, that may or may not be possible in high-income countries. Not possible here. Look at big data sets for insurance. There's a whole gymnastics that you have to go through to get sort of health cost data that represent the country. Middle-income countries have done, there are a couple reports in Brazil and Colombia should use national data to report this. This is importantly upper middle-income countries. But Mongolia at the time, it bounces between lower and middle, and that's somewhat of an advantage, depends on their economy. They were a lower middle-income country during this period. And they had the advantage, it's caused a lot of grief over the years, but one good thing about being formerly communist, formerly Soviet adjacent, is that you have a very top-down health system that's easy to collect data from. In fact, even district hospital or inter-district hospital has a statistician on board sending information to the capital, Ulaanbaatar. Good for me. No other lower-income country had been able to do something like this without using what we might refer to as, lesser ways. These would be going through paper log books around the country, very tedious. Sometimes this is like big, globally motivated cluster data collection. And it sort of list goes on, but it's pretty tedious stuff. Could just be log reviews, could be prospective, but they're not as great as having data flowing in. Certainly, if you're carrying out a big chart review across the nation, you're not doing it every year. So, big advantage here. So we chose to do an 11-year retrospective review of their national health data. This is public hospitals, which is one limitation. But in Mongolia, the private hospitals are mostly in big centers or big urban centers. There are a couple that do some advanced surgeries. Most of them are kind of doing the bread and butter stuff, and they don't actually increase access to anything, or not much. If you're a nomad, you're not going to come across a private hospital. So it makes sense. It's reasonable to just look at the public system. So there were 81 public hospitals that we deemed to have surgical capacity. And because of this level of sophistication, we were able to disaggregate. So not just look at national statistics, just one little number, we could divide it up by region and see where the workforce density was different, where the disparities were. And so what you'll see here are each indicator with a target on top and how Mongolia fared. And I think you'll learn from this that the difference between national and subnational disaggregation in the next few slides. So the target set by the Lancet Commission were 80%, or over 80% of people within 2 hours of access to essential surgery. Mongolia seemingly beats this. Workforce density, the surgeons, anesthesiologists, and obstetricians, you want about greater than 20 total 400,000 population. Goodness, Mongolia gets 47.4. Surgical volume, they beat the 5,000 target per 100,000. Perioperative mortality, the goal is just to measure it. Great. And the financial cost, sort of a mixed bag, and we'll get into that too. So 2-hour access, the 81.1% coverage is really because half of the population lives in and around Ulaanbaatar. That's where all the tertiary centers are. And so by the way we measured it here, half the population has access. Now that doesn't take into account traffic patterns, seasonal differences, referral patterns. And then when you move outside of the capital, so everyone outside the capital, only about 60% of that population has access to surgical care. And then a later study that we published, and then in a subsequent one, we kind of kept looking into things, getting into more detail, and we add in topography, changes in river flowing patterns and the like. We see that rural access drops down to, I think, 54%, and overall access to the country moves down to about 76%. So that sort of speaks to methodology questions that the geography literature, GIS, geospatial access. There's arguments there. We should make it simple. And in one respect, you should, so you can pull it off. But the more detail, it gives you more information. And each of those have their uses. Moreover, what is a bellwether hospital? And this doesn't exactly work. In Mongolia, as a post-Soviet nation, no hospital in the capital does all the bellwether procedures because it's a very siloed, fragmented system. There are a lot of post-communist countries in the world you can't use the bellwether metric for. And so we're currently trying to sort that out. It's an important question that I don't think anyone's asked because no one's tried to measure this thing in a post-communist country. And so, yeah, this enabled us to make a recommendation, which was how to best address this deficit in care, how to give more people access rurally. We're able to say, upgrade these specific inter-district hospitals, and you'll bring access to 100-something thousand more people. Take a look at it. And you can add hospitals in these strategic locations. Other things you can recommend or upgrade these certain roads. Mongolia only has 4 or 5 major roads in the country, and the rest are just these braiding dirt paths. Gotten car sick. A lot of them. Workforce. So we can see that overall workforce is 47, way above the goal. Obstetricians alone are more than 20K, but when you dig into the data, about half of the obstetricians don't actually perform C-sections, so they're not actually performing surgery. So another important kind of tidbit to work out. And then looking at that sort of subnational disaggregation of workforce disparities, we're able to see there's some district hospitals, some areas with maybe not enough, or maybe no anesthesiologist, maybe not a surgeon. So we're able to kind of dig in and see where things can be upgraded. Surgical volume is interesting. Again, the next few slides will show the power of looking at things year by year. And Mongolia didn't meet the threshold until 2014. They just started doing more surgery? Well, no, they just started measuring it differently. They found ICD-10 too tedious, so they jumped back to ICD-9, which captured outpatient surgeries better. Lo and behold, we meet the party now, the line. Perioperative mortality, kind of dropping over the years, but that's a good sign. That perioperative mortality is way lower than other lower middle income countries that are usually 1%, 2%, maybe half a percent to the mid ones. And having worked in Mongolia a number of years, a lot of countries in the world don't have the same culture of transparency, like quality improvement. So this morbidity mortality conference, it's so kind and benign here, and so terrifying in the South where I train. But it's transparent and it happens and things improve, and it's not happening in Mongolia because you can go to jail for a complication. And so there's room. We now have numbers for maybe looking a little closer. For impoverishing expenditure, as well as catastrophic expenditure, we didn't really have any direction. You know, what is there a certain surgery that is representative of all surgeries? We just pick one, pick a mean, median, an average. Some of the modeling studies that came out at first for the Lancet Commission, that they looked at C-sections. And that's only because there was decent cost data in the WHO database for C-sections. And so they sort of modeled the whole thing. And we were sort of the first study to use actual cost data to look at these costs. And we did that with national health data cost information. So this sort of illustrates part of the problem. The C-section is the green. That's what's touted as sort of probably gaining momentum, as we'll get into later, as the representative for at least the initial look. Everyone's protected because Mongolia has universal health insurance or national health insurance, which is amazing. But there's still costs. So it's not technically universal health coverage or health care. And the other, my point is, with the laparotomy and the appendectomy, or in the laparotomy, appendectomy, and C-sections fail to account for is informal costs of getting surgery in post-Soviet nations. That often comes with a tip or a bribe, depending on your culture, to the surgeon, because the surgeon's underpaid and you know it. So in some cultures, maybe everyone pays a certain amount. In other cultures, maybe if you have money, you give money. If you don't, it's understood that that's okay. We don't really know. This also gives us a view into some of the legislative changes that happened over this decade. For lab coli, which we're particularly interested in because that's what we've invested so much time in, the cost has gone up. And the whole reason we did, or that Dr. Price was convinced to teach laparoscopy in the first place, was because that lady in that ambulance, little spot out in the Gobi Desert, has to get back to work, taking care of her home, tending to her sheep, her goats and her sheep. If you can't work in a lot of parts of the world, you can't eat. And so if you have smaller incisions, you get back to work faster, everything's better. It turns out the national health insurance stopped covering everything around 2012. Flip side of that, if you look at cost of an X-fix, this is what we chose to look at instead of internal fixation, just because there was no guidance. We just picked one. That cost went down, reflecting legislation that covered more of the hardware. So just an illustration that we can tease out more than you would expect from, depending on the way you do these things. Catastrophic expenditure shows basically the same thing. So a lot of the problems I just brought up, or a lot of the questions that arose, especially as more and more countries were reporting these things, turns out we couldn't really compare them because we were all doing things in different ways, slightly different ways. And so in 2019, some of the leaders from the Lancet Commission partnered with World Federation of Societies of Anesthesiologists and the Laird Al Foundation to undergo an Utstein consensus process. Now, the Utstein consensus process is established. It's the reason we have international CPR standards. That was sort of the first one. And they've done a lot of perioperative projects since then, and this has been their, to my knowledge, the latest one. So in 2019, they got together and said, define things a little better. Made this a lot more straightforward. In 2021, a second process consensus process and meeting was called. And Dr. Jayaraman and I were fortunate enough to be on a writing group with the spatial access bit. That turned into my attending the second consensus process at the Utstein Abbey in Norway, which was wonderful, and sort of hashing out basically a how-to manual. There's metadata, a data dictionary, a lot of the kind of nuts and bolts of things. And at the end of that conference, commissioned 2 pilot studies, which we all applied for. And then our collaboration in Ghana was fortunate enough to get that grant. And so I spent most of 2023 doing that, which was a whole lot of fun, made a lot of really brilliant friends. And I think we achieved a whole lot. One important thing to come out of that, this was something the Lancet Commission intended, if you read their report on global surgery, which was that we would move from national to subnational and disaggregation as things matured. And so Utstein consensus formalized this, divided into basic, intermediate, and full data sets. Now, importantly, the basic data set is what we think of as indicators. We're going to use it to track global processes. And now that they're better defined, we've stated sort of preferred methods of collection, depending on your basic World Bank income classification, what's available to you. We can have a better comparison. Most countries should be able to just produce these things immediately, or at least within 2 years. Again, they're at national level. And then intermediate and full should, once the commitment is there, hopefully people can get this reported within 2 to 5 years of making the decision, and then for full greater than 5 years. There's a subnational, regional, they're disaggregated. What do I mean by disaggregated? That means if we're looking at surgeries, is the surgery emergent or is it elective? Is it outpatient? What kind of surgery was it? People producing lists of what we call essential surgery. That's going to come out probably in the full data set for this. So for workforce, divide that up by surgeons, anesthesiologists, and obstetricians. And the point of all these things is to assist national planning. So you're tracking on this side, and now we've got our problems. We're going to dig in, and we're going to make a national surgical plan, but we need better data than the light stuff. So we were tasked with collecting Ghana surgical indicators as a feasibility project at the basic level. And so here I am again, volunteered to collect these indicators in a lower middle income country. So far, Mongolia is the only one to be able to do it through national systems. But Ghana has some advantages itself. It's like Mongolia in some ways in that even though it's much more populous at 32 or 33 million people, it has a sort of north-south divide, and the south is much more urban than the rural north. And they instituted a national health insurance plan about a decade ago, I think. And thankfully, they use the DHIS2 platform. If you're not familiar with that, it's a product or a platform from the University of Oslo called the District Health Information System. It's now in its second version. And just provides a platform for an EMR that countries can sort of tailor to their needs. It's open source, and it's used by about, I think, 72 LMICs around the world. And so, theoretically, what I can do in Ghana, or what we can do in Ghana, what is able to be accomplished in Ghana, they eventually be able to be accomplished in a lot of other countries and affect a lot of the rest of the world. So the way it worked out was the first 4 indicators we were able to collect from the system. And data out-of-pocket costs for prospective, or for the cost financial risk indicators, we didn't have available in Ghana, which was the sort of ideal method, which was a national health cost survey. It's not for surgery. And so we had to sort of reproduce one. So that was the bulk of the work, which is a prospective health cost survey with patient exit. So what we did was worse in Ghana, you can't leave the hospital until you pay your bill. And so before you leave the hospital, you know what you're going to pay. And then we followed up by telephone, I think 30 days later. We were able to collect all kinds of things. How much did you pay for surgery? How much were your medicines? How much did it cost to get here? 30 days later, did you have a complication? Did you get back to surgery? Or how much did it cost to get back to get checked out? How many days of work did you miss? And so this is giving us beyond basic. It's giving us, because Einstein consensus defined the basic level as a C-section, the direct medical cost in hospital of a C-section. We were extra. We did all the other stuff to see what was possible. So we got informal costs, out-of-pocket costs, indirect, lots of stuff. So here are the indicators. I neglected to mention that one of the outputs of the Einstein process was to drop impoverishing expenditure. There's a whole economic theoretical argument behind this, which is part of the reason I went to grad school that I won't touch on. But just basically make things simpler, to lower the bar for people to collect them. For preparedness to our access, Ghana falls just short at 76%. And when we add sort of more layers, that may fall just like Mongolia did. The workforce density seems adequate, but it's because basically mid-level providers, physician extenders, and more so general practitioners are doing a lot of the heavy lifting there. And so the definition is now, can you do surgery? Can you do a C-section? Or can you provide anesthesia care? And a lot of that in the district hospital level is done by general practitioners or these medical officers. So this workforce isn't necessarily certified surgeons, anesthesiologists, and obstetricians. And that as we report sort of intermediate outcomes, we'll be able to look deeper into that. Surgical volume is well below the 5,000 target, and this lines up with a previous case log review that was done by my co-PI years ago. And so at the very least, we can tell that this national health system query is at least as good as, or almost as good as, hand review with a whole lot less work. Perioperative mortality, it's 1.06, which is in line with the previous report from Ghana and other lower mid-lung countries. We ran into some trouble there because, well, I'll get to that in a sec. Catastrophic expenditure is interesting because 100%, just like Mongolia, 100% of people are protected from catastrophic costs of a C-section. So when we looked at long bone fixation, we looked at laparotomy, a lot more people were affected. So if you just look at the basic bit, you're not. Takeaways. We ran into challenges. Right now, their health system is disparate. Different levels of hospital have different systems. And so we kind of muddled through it. It's not perfect, but it's feasible overall. Now those disparate systems are giving way to the system that is currently just implemented in the past few years into the tertiary hospitals and has made their way into the regional hospitals, also based off DHIS2, will eventually be adopted by the entire public system. And that's a huge opportunity for providers in Ghana or public health officials to routinize this indicator collection. For instance, the other pilot study in South Africa just looked at postoperative mortality and surgical volume using an app that was laid over the DHIS2 system to routinely report this. And so as the Ghana Ministry of Health and the Ghana Health Service implement this and build it into processes, it's a golden opportunity to not only integrate surgical indicator collection, but a lot more indicators overall. So Ghana could reach a place where the argument between the International Health Metric Evaluation Center, Global Burden of Disease in Seattle, and the WHO, these ideological headbutting, Do we measure metrics from Seattle? If we don't have your data, we'll kind of compare you to someplace similar. That's probably good enough. WHO, which uses country data, maybe it's accurate, maybe it's reliable. We could come to a point in the near future where we have actual real-time data from systems like this, and Ghana could be on the forefront. The other thing we pulled out was that we can't do a detailed patient exit survey every year or every couple of years. That's impractical. We did it in, I think, 6 hospitals. It's a lot of work. And so we could probably implement basic cost questions into existing health surveys, DHS or the like. Feature studies, basically a fuller report of what we've done, and really taking the angle that the point of the indicators is to be viewed through that whole lens, that whole conceptual framework of access. How do we interpret the full extent of our findings through that lens? We're going to tackle financial risk by itself because it has implications bigger than what the definitions of UTSIGN has put out. And again, if we can find a way to encourage and assist the routinization of the collection processes into LIMS, which is that routine health information system that's going to be taking over. So how do we innovate future metrics? Number one is the real-time collection that I seem so excited about. Give more accurate and timely insights into health systems. A lot of people would really like to integrate some qualitative aspects into our sciencey data collection, which I think is a worthwhile affair. More cultural touchstone into these things, and really pay attention to local adaptation and customizing metrics to reflect regional realities, like in Mongolia, where bellwether access doesn't mean much in the capital. So we should adopt the flexible use of metrics. Ideally, it's just a signal that we look further into. It's hard when they make headlines and talking heads are kind of comparing these things. Headlines are blown out of proportion. We need to ensure metrics reflect population realities, where they are, and we need to maintain accountability while adapting. I should mention a big team, or what was so rewarding to me about a lot of this work is how multidisciplinary it is. I work very closely with a PhD candidate in geography named Andrew Davis. Worked closely with several economics PhDs, the latest of which has been Maura Doherty. Just brilliant people who are doing this stuff because they really love it. So it's been extremely rewarding for me. Thank you for your attention. I'm happy to answer any questions.
Thank you, Jade. I think that was fantastic. I will look out for questions in the chat if you can moderate in person. But I just want to say that that was a fantastic overview of how we think about data and access to care. And I think it applies to all of our specialties and all of our fields, which is why we should have meetings like this. So thanks so much, Jade.
Pleasure.
How did you engage the government, and are I guess people who's part of the health ministry able to make use of your data? Have they done anything with your data?
We have an advantage in Mongolia, being partnered with influential surgeons. The other advantage is that Mongolia is small, so there's a good chance that our colleagues know Minister of Health or even the president potentially. And so, the plan, the national surgical plan that our colleagues were working on sort of stalled due to the main disadvantage of working in Mongolia, which is so getting traction there has been very good. But just with every change in government provides you an opportunity. But it's working with the Ministry of Health and proved actually quite easy because they're very engaged papers they like to publish, and they're it's best for the operation. In Ghana, all credit to my co-PI, has done this sort of work before in Ghana, knows how it works, it's pretty well connected. Now we learned some hard lessons. We started with probably too high a level. I mean, one of the big things we learned was that locate and work with the correct stakeholder, someone who's invested, and it's dumb luck to find the right person eventually. So yeah, connections and dumb luck.
Where, if at all, does access to comprehensive post-op care fit into those indicators?
Assumed. If you can provide those services, you're also doing the post-op care. Now that also speaks to like a advanced pre-hospital system, which is a whole other bag. Very much worth people's attention and money. In Mongolia, that is a big problem, as you can imagine, because each district hospital has an ambulance or two. Some of our colleagues perform C-sections and laparotomies in a ger or yurt for 3 hours. So these are very dedicated people. That's a wonderful question. I think that would be great hospital indicators. Well, thank you all so much. I really enjoyed it. Like Dr. Jayaraman says, next month, Drs. Watt, Kamani, Suneda talk about cancer and stigma research, which sounds fascinating. So I'm really excited where this is all heading. Thank you for making this so pleasant.
Thanks, everybody.